Thank you for inviting myself and Dr. Mollie Minear to present on the behalf of NICHD and talk about some of our newborn screening research and some of the supports that we are providing for investigators. We are very pleased to be able to present at this year's annual NBSTRN network meeting and are pleased that there are so many people interested in newborn screening research who are participating today and tomorrow. Today, we are planning on focusing on four basic areas that we would like to address. The first is discussing the history of newborn screening research at NICHD and some speculation about what the future holds for newborn screening related research. And then after I present these two elements, Dr. Minear will talk about finding funding opportunities for newborn screening research and some tips for how to prepare a good NIH application. So we're going to give you some of the history and background, and then we're going to tell you how to apply for some of the money that's available to support newborn screening research. So for starters, let's talk about the history of newborn screening research at NICHD. A lot of what we are currently supporting began with the Newborn Screening Saves Lives Act of 2007. And this legislation, as many of you know, really established grant programs for state and local public health agency to provide screening and services for newborn screening conditions. This was instrumental in providing for the education and training of laboratory personnel to support newborn screening. And very importantly, it codified the advisory committee, what we know as the Advisory Committee on Heritable Disorders in Newborns and Children, to review conditions that could be added to the recommended uniform screening panel. In addition, this legislation established some very specific roles for the federal agencies, and I'll talk about NIH's mandate in just a moment. Prior to this legislation, we were supporting a variety of different newborn screening related projects, mostly investigator initiated. By that, we mean an investigator who was very interested in a particular condition would actually write for a research grant, sometimes a cooperative agreement, and in some cases contracts, to help fill those gaps that they perceived. In addition, there were some small business awards that were also supported under the auspices of some of our newborn screening related research grants. But it was not a very unified or a very systematic approach to supporting newborn screening. So it's really with that legislation and the incorporation of the Newborn Screening Translational Research Network that NICHD took a systematic view towards newborn screening related research. The NICHD has named its research program that focuses on newborn screening in honor of Hunter Kelly, whose picture is shown on this slide. And this is really what our mandate is under the Newborn Screening Saves Lives Act of 2007, which was also reauthorized, as you know, in 2014. So we are charged with identifying, developing, and testing the most promising new screening technologies, developing treatments and management strategies for conditions detectable through newborn screening, providing research findings and data for newborn screening conditions that are under review by the advisory committee for consideration to be added to the RUSP, and importantly, also conducting pilot studies on conditions recommended by the advisory committee. And the ways in which we have been fulfilling this mission is really through three main mechanisms. One is dedicated PARs. A PAR is a program announcement with a specified review. And this includes efforts to try to support screening technologies and management strategies, as well as natural history studies. We have also supported a variety of different contracts through what we call an IDIQ mechanism, which means indefinite delivery, indefinite quantity, which allows us the maximal flexibility to help support pilot studies for conditions that are either under consideration or we think are likely to be considered for addition to the RUSP. And underlying all of these strategies has been our support of the Newborn Screening Translational Research Network through a contract that is providing infrastructure to support these activities. So just to give a little more details about the newborn screening research and some of these, what we call FOAs, but we know not everybody knows what that refers to, but really a FOA is a funding opportunity announcement. And we have had these innovative screening approaches and therapies for screenable disorders, PARs, on the street for quite a few years, starting in 2006. They're currently in a 3-year iteration that began in 2021. That's what that second digit, PAR 21, refers to. And this particular suite of FOAs supports 3 different fundamental mechanisms of grants at NIH, the R01, R03, and R21. And this is fairly broad and allows for support of new screening paradigms for conditions that have the potential to be screened for, as well as development of treatments and therapies for conditions either on the RUSP or things that have the potential to be added to the RUSP. In addition, we have a program announcement with review for natural history of disorders screenable in the newborn period. And these are really for those conditions that may fall through the gap that really need to have better understanding of the onset of symptoms and the complications of a disorder. These types of studies help groups accurately diagnose the disorder, understand the clinical heterogeneity and the phenotypic differences of the disorder, potentially identify the mechanisms that underlie the basic molecular defects for some of these conditions, develop strategies that prevent, manage, or treat the symptoms and complications of the condition, and provide information to children and their families that will support and provide predictive information for them as they grapple with a condition that in many cases is going to be quite rare and there may not be a lot of information available about. So those are the 2 broad categories of newborn screening focused funding opportunity announcements available through the NICHD for newborn screening. A second way that we support newborn screening research is through the NBS TRN. And you all probably wouldn't be here at this workshop unless you knew and or were familiar with the NBS TRN. But this is really an infrastructure to provide the research community access to newborn screening research related resources. And in many respects, the NBS TRN serves as a coordinating center for newborn screening research projects. There are a number of current projects that are funded through a variety of grants and cooperative agreements that are utilizing the resources of the NBS TRN to support their projects. This particular resource also provides data sharing, state level policy, and information about the various conditions that are a part of the RUSP, as well as conditions that have the potential to be added to the RUSP. Finally, the ELSI Advantage aspects of the NBS TRN provide information about the ethical, legal, and social issues related to newborn screening, which are important and certainly need to be addressed. And then finally, we have a group of newborn screening related pilot studies that we support through the contract mechanism for conditions recently added to or recently having been recommended for addition to the recommended uniform screening panel. What we do is every 5 years, we compete a pool of contracted sites. Mostly these are state newborn screening programs, and that pool of sites is basically the group that is allowed to put in specific proposals each year when we compete a given task order for a specific condition that we think needs pilot data to help support a nomination for the RUSP. Each of the contractors that's a part of this pool needs to have a high throughput newborn screening laboratory. It can be state run or private. They need to have the capacity to screen at least 50,000 newborns and sometimes up to 100,000 newborns within the span of 1 to 2 years, and the ability to develop, implement, and demonstrate proof of concept for new newborn screening technologies. The states that are part of this pool of contractors are those that tend to be very focused and enthusiastic about embracing research projects that will help establish some of the paradigms for future newborn screening of new conditions. This is a graphic illustration of the timing for the different pilot conditions that have been supported under this IDIQ contract mechanism. And you can see that in 2014, we started with Pompe disease, and then over the span of the past several years, we have provided pilot data that has really helped with the adoption of many of the new conditions that have been added to the RUSP in the past 5 years. In particular, for this current year of 2022, we have just released the request for proposals to the states that are part of the IDIQ pool to put in an application to screen for congenital cytomegalovirus, or CMV, for the next 2 years. And we're looking forward to seeing what the pilot results will show for this condition, because as you all know from past experience, each new condition added to the RUSP has its own unique issues, potential challenges, and opportunity to learn more about the condition and what it really means to test it in the context of a real-world laboratory experience. This slide illustrates some of the newborn screening research that has been supported by NICHD over the past 15 years. And what you'll notice, and this is certainly not meant to be comprehensive, but starting in the mid-2000s, we were supporting relatively small amount of research related to newborn screening, really only on the order of about $2 million to $6 million in those first few years. And then with the addition and the support of the NBSTRN, some of our focused funding opportunity announcements, and really in response to the legislation in 2007, we've been able to increase our support significantly into the more $15 to $20 million range per year. And that includes a variety of different contracts indicated by the blue line, and the total number of projects is indicated by each of the gray bars for each year. So we think that this represents fairly steady and consistent support for newborn screening related research, and we're certainly hopeful and optimistic that this trend will continue and potentially increase in the future. One of the aspects of the research that is supported by NICHD is really, as mentioned before, to support nominations for conditions to be added to the RUSP. And as most of you know, this is a complicated process and one that requires partnerships on the part of many agencies and advocacy groups. So we've developed this graphic to try to distill some of this complexity into a digestible graphic that we think will help provide some clarity for groups that may be interested in nominating a condition for the RUSP. If you look at that top group of balls on the upper left, these represent the sort of preliminary work that needs to go in to a nomination before it's even submitted to HRSA for consideration for addition to the RUSP. And we've got a color-coded legend off to the right, but if we focus on NICHD's role, and that represents the red areas that are colored in on those balls, you'll notice that we support a lot of basic science research. We are involved in some of the epidemiologic and health services research. Certainly, we have supported quite a bit of research that develops screening assays for new conditions and treatment studies for conditions that can be added to the RUSP, as well as the support of pilot studies that I just described. In conjunction with our colleagues at CDC and at AHRQ, we support some of those epidemiologic studies and assay development, as well as FDA support of development of new assays and treatments, and provisional approval so that those can be adopted for new conditions that are nominated. The role of advocacy groups, clinical and research experts, and many others in gathering a nomination team together and submitting a nomination, as indicated in the orange, cannot be underestimated. And then once a nomination is actually put together, the submission process, the review process by the advisory committee, the multiple stages of recommendations that ensue, and then the action on the part of the Secretary of the Department of Health and Human Services on whether or not that condition should be added to the RUSP is a fairly lengthy and a very rigorous process. Once a condition is added to the RUSP, the federal role is not completed. And in fact, our colleagues at HRSA and CDC are very involved in providing QA materials, technical assistance, and implementation assistance that will help with the adoption of a new condition by the states, as well as long-term follow-up education and continuous improvement. So I'd like to pivot and just talk a little bit about the future for newborn screening research. And this is clearly not the fact that we have a crystal ball to talk about what the future holds, but some of our speculations based on the research that has been supported by NICHD and others over the past decade or so. A brief look at the history of some of our new initiatives and newborn screening research and how it relates to genomics. Back in 2010, which seems like it was a long time ago, but really was only 12 years ago, we supported a workshop called Newborn Screening in the Genomic Era, setting a research agenda. This was a collaboration between NICHD, NHGRI, and the Office of Rare Diseases Research. And I want to remind everybody that back in 2010, genomic sequencing from dried blood spots was not available. It wasn't even sure if it was feasible. And most newborn screening programs did not have any sort of significant or regular DNA sequencing algorithms as part of their programs, aside from sequencing for particular variants in the CFTR gene that underlies cystic fibrosis. So sequencing was really not on the radar screen for most newborn screening programs. And the purpose of this workshop was to define the technical considerations for conducting genomic sequencing on samples from dried blood spots, explore the value that genomic sequencing could add to newborn screening, and address, very importantly, the ethically related issues for this potential paradigm shift in newborn screening. As a consequence of this workshop, further deliberations, and a lot of work behind the scenes on the part of a number of different program officers and researchers and others, we developed the NSIGHT program. This stands for the Newborn Sequencing in Genomic Medicine and Public Health. The purpose of this initiative was to explore the implications, challenges, and opportunities associated with the possible use of genomic sequence information in the newborn period. This was a joint program between NICHD and the National Human Genome Research Institute. There were 4 projects funded with the sites as listed, and the projects were actually completed in 2019. So this was about a 5-year program initially, but it had some carryover and was completed in the span of about 7 years. But each of the projects that was proposed and ultimately funded needed to include a genomic sequencing component, a clinical application relevant to newborn, and importantly, the ethical, legal, and social implications of that research and that genomic sequencing. There were a lot of findings that came out of this program, and the 4 different projects, each of them was unique and different in its own right. But we think, and this is, obviously a biased summary of what we think came out of this, but I think that there was an emerging understanding that rapid whole genome sequencing could be performed as a first-tier diagnostic test for inpatient infants. So these are usually really ill newborns in the neonatal or pediatric the neonatal or pediatric ICU setting. And in some cases, whole genome sequencing could provide a diagnosis in up to 60% and changes in treatment or management, including withdrawal of care in cases where a very devastating condition might have been diagnosed, in up to 65%. And the findings from the team that was really focusing on the NICU setting was that rapid whole genome sequencing was actually superior to whole exome sequencing in coming to an answer promptly and comprehensively. Several of the groups identified panels of genes that could be tested in newborns due to their early age of onset and medical actionability. And this really, I think, is setting the stage for the potential utility and value of sequencing in healthy newborns. You may not envision doing whole genome sequencing on every newborn in the immediate near future, but if you could identify the genes that have the greatest impact for newborns and children, that could be a targeted approach that might be an interim step. It was noted that looking at babies with known newborn screening disorders, if you compared head-to-head sequencing-based technologies, those technologies identified about 88% of infants with known newborn screening disorders, but they missed a certain proportion as well. So the thinking is that really traditional tandem mass spectrometry methods have a higher yield overall, but there was the recognition that sequencing has a role, particularly for second and third tier testing and increasing the sensitivity and specificity of newborn screening. One of the groups developed an evidence-based and validated online tool, a decision support tool that can support parental informed decision-making about the use of genomic testing in newborn screening, and was able to test this tool in a variety of different settings and found it to be quite valuable. Most of the groups found that from their LC projects that the impact on families from the newborn screening, the psychological impact was not as high as might have been predicted, but there's still concerns about the vulnerable child outcome that can occur with identification of an otherwise healthy appearing newborn with a condition that may have a later onset of disease and potentially have implications down the road. But most of the groups also recognize that more data are needed to really understand these impacts in greater granularity. And certainly the groups also concluded that there is a need for data on more diverse populations, as many of the studied groups were rather homogeneous in their composition. So those were some of the findings from the NICHD program, but it has been a very valuable program to help us really explore at the research level what it means to consider sequencing, genomic sequencing in the newborn period. Fast forward 11 years, and last June in 2021, we supported a workshop on gene-targeted therapies, early diagnosis and equitable delivery. And this was designed to say, okay, now here in 2021, what do we think might be feasible to implement gene-targeted therapies in the future while addressing the very real concerns related to the efficiency, the cost effectiveness, and the equitable distribution to all at-risk infants? Can we think about gene-targeted therapies and how they could actually be applied for newborns? This was a 3-day workshop, and the first day was really looking at the who, what, and when of who could benefit, what approaches would be needed, and when would be the optimal time to identify individuals who could benefit from such gene-targeted therapies. And when we're talking about these gene-targeted therapies, we're really thinking about oligonucleotide therapies, virus-mediated gene replacement, and somatic genome editing. So these are really cutting-edge technologies that are not yet routinely used in a population basis, but we're really trying to anticipate what the future might hold. Day 2 of the workshop identified existing systems that could be leveraged or adapted to bring treatments to these individuals who would most benefit from them. And day 3, importantly, focused on identifying gaps that need to be addressed to facilitate the dissemination of these treatments in an equitable manner and an ethical manner as well. If you're interested in knowing more about the workshop, I've included the website here, and we have recordings available. It was a very stimulating workshop, and there are a number of papers that are under development and a future special issue that will be compiling some of the salient discussion topics and conclusions that derive from that meeting. So I think that the emerging questions in newborn screening research that we need to be thinking about and need to address, and we welcome your input into these as well. But here are a few for further thoughts and cogitation and comments. Can the approach to single treatable conditions be expanded to include a group of conditions for which early interventions are the mainstay of treatment? I think most people feel that this single disorder by single disorder approach may not be the most effective for adding conditions to the RUSP. At the same time, though, when we add a lot of conditions to the RUSP, leading to the second question, that puts a strain on the system, and that also does potentially add to the struggle of newborn screening programs that are trying to keep pace with the increasing number of conditions that are either candidates for or have been adopted not only on the RUSP or by state newborn screening panels. So these are very real sort of diametrically opposed issues that I don't think we have solutions to yet, but need to be considered. Another consideration is whether newborn screening could be expanded, to include conditions where the diagnostic odyssey could be alleviated, even if there is not a specific treatment yet available. And, you know, this really speaks to the power of providing knowledge for a child and family that could improve quality of life. I think these are really challenging issues and ones that really need to be considered carefully. And NIH and NICHD are working very hard to increase the diversity among research participants and researchers. And this, of course, is something that's really important to ensure that all of the research that we support through NIH is addressing the needs of underrepresented communities, that is gaining the trust of those communities so that they are interested and willing to participate in research, and so that they are going to feel confident that the results that come from research are actually going to be inclusive, that are going to speak to their needs and be equitable with regard to accessibility for whatever comes from that type of research. Corollary to that is that we need to bring more diversity of our trainees into the newborn screening research field, and we welcome your suggestions on how to do this. So the bottom line is we want to be at the cutting edge of some of these new genomic technologies, but we need to make sure that newborn screening research doesn't damage the trust in newborn screening programs. So this is the final slide for this first half of this presentation, but we have a couple of questions that we want you all to ponder and to provide some feedback to us. What do you think the future of newborn screening research should look like? What should be our priorities at NICHD for newborn screening research? Can we safely incorporate new technologies into newborn screening? And how can we better support newborn screening researchers, families, and communities? So we will be publishing a request for information, and we look forward to you all providing your feedback to us at NIH to help give us some guidance in terms of what you think the future should look like for newborn screening research. Thank you. And now I'll turn it over to Dr. Minear.